And here we are, altered renal function, aka renal pathophysiology. But it's going to include pretty much all of the urinary tract. Having said that, let's go to the first slide. So there are three ways that the kidney can be injured. And the classification of these pathophysiologies are one of three. It's either pre-renal, which means the damage was done before the kidney, but that damage is going to affect the kidney. Intrarenal, which means in the kidney or in the renal area where the nephrons are. And last but not least, post-renal. Post-renal would mean that you had the ureters and the bladder involved in the pathology so that something happened after the kidney that then could damage it. So we are going to explore pre-renal, interrenal, and post-renal pathophysiology. This is just a brushing up and brushing off of cobwebs. The other thing that I would recommend is to look at normal renal function and to go over that. And having said that, this is a cross-section of a kidney. And what you have is you do have an outer cortex. And then the middle or the medulla is fairly complicated. You have these are called pyramids. So you have the renal pyramids, and then the renal pyramids are where urine is going to be formed. And once urine is formed, it then is basically squirted out a nipple into the pelvic region. These are called minor and major calyces. And then the reason why these are yellow is to indicate urine. And so every one of these pyramids makes urine, and then they pass into the minor and then the major calyx, and then pull in the pelvis of the kidney, where then it can be transferred, or then it flows down the ureter. Okay, this is showing you the entire excretory tract, urinary tract. So what comes in to the kidneys is via the renal arteries. And what comes out of the kidney is the renal vein. And you have, so that's the blood supply. And of course, the whole idea is to be able to take toxic substances and to adjust pH and to help with the synthesis of vitamin D, adjusting pH, and all of that. And I think people tend to think about the kidney as purifying blood, getting rid of all those toxins, and then that goes into the urine, and then you urinate it out of your body. So as far as the tube structure goes, when you form urine, it leaves the kidneys via the ureter. Now the ureter is actually smooth muscle. I want you to think of the ureter as your esophagus. So your esophagus moves food, water via peristalsis. So you have a one-way movement of food: mouth, esophagus, stomach, intestines, rectum, anus. We all know, however, that you can have reverse peristalsis in the esophagus, and that's what happens when a person vomits. And believe it or not, you can have the same thing happening here, where the kidney is making the urine. The urine is going to pass down the ureter because of peristalsis. So that peristaltic wave is going to, most of the time, move the urine from the kidney down the ureter to the bladder. And the bladder, sometimes called the detrusor muscle, is able to expand. And so it will fill up with a certain volume of urine, and then that would trip off stretch receptors. and then that would feed back to the brain, and you can, as an adult, have a certain amount of control over when you're going to urinate, and other times it gets there's an override, and you're going to urinate no matter what because it's just too full. And of course, what then happens is that when you're going to urinate, that bladder detrusor muscle contracts and pushes the urine. And then the urethra, which is very small in women, much larger in men because it threads through the penis. But then the ureter have two sphincters that open so that you can urinate or void the bladder. Another term is micturate. All of these are fancy terms for urinating. And so that's it. So it should be kidney, urine goes down ureter to bladder, holding tank, and then when that contracts and the urethral sphincters relax, you void the bladder, and away we go. We're going to find in some cases there is the ability to infect the urine, inflame the bladder, and to irritate the muscle of the ureters enough so it does reverse peristalsis. But then it means that you're basically taking that urine and it's moving against, right? It's not supposed to be going up, it's supposed to be going out, and it's infected. And so the pelvic structure of the kidney and the calyces can be affected, can cause inflammation and so forth and so on. So that's the reason why I emphasize the peristalsis going on here. Okay, 1 million microscopic nephrons. They are the functional unit of a kidney. Per kidney, you got 2 of them, so you got 2 million. Yay! They are irreplaceable. If there is damage to any part of that tube structure or any part of the capillary structure, but we'll just zero in on the tube structure, it's gone. We have no way, the body has no way of replacing it, regenerating it. So very often with a lot of these pathologies, you have an acute episode, and then very often you can knock it down with anti-inflammatories. But if after the acute incident that person has lost 20% of renal function, that's gone forever. You're going to then hope to hold on to the other 80%. And there are some of these diseases that, if they become chronic, are going to chronically and progressively destroy the kidney. So here's the nephron. So the nephron's in yellow because it's going to make the urine, and then the blood is obviously red. But now you've got arterial blood coming in. Now here comes the arterial blood coming in at the top. And I'm not going to test you on this as such. They did that in AMP1, but what I want to emphasize is that knowing the names is going to help you out a lot. So for the tube structure, okay, let's do the blood structure. Afferent, meaning the first coming into, so you have the afferent arteriole, which can undergo vasodilation, vasoconstriction, and it's going to come into that nephron structure at the beginning. This cup-like structure is called Bowman's capsule, and the afferent arteriole breaks into the first capillary bed. The capillary bed is called the glomerulus. And this capillary bed is where you can first filter plasma into the tube structure. Plasma minus blood cells minus big plasma proteins and other very large molecules. It's only going to be what is dissolved in the plasma of a certain size that can get filtered into the kidney tube. That filtration is going to occur here in the glomerulus. So you're going to filter a certain amount of volume of your blood plasma that contains all kinds of toxins and things that you want to eliminate. And it's going to push that into the tube structure at Bowman's capsule. Then once it's done that, is going to take what it hasn't filtered and move that into the efferent arteriole right here. And then it breaks into a second capillary bed. And this capillary bed is called the peritubular capillaries. In some cases, vasorector, but the majority of the nephrons are cortical nephrons, so most of these are peritubular capillaries. That means that you can exchange small molecules in the tube structure. So your first capillary bed is all about the glomerulus and Bowman's capsule and defining what's going to go into the tube. And then the peritubular capillaries allow you to adjust. So the tube structure begins, and then the peritubular capillaries become the renal vein and then out the kidneys. So the tube structure, so here's your nephron. You've got that cup named after Dr. Bowman, so it's called Bowman's capsule. And then the filtrate it's called, because it's not urine quite yet. So the filtrate, kind of the good, the bad, and the ugly, everything, is going to go down the convoluted tubules. And this is the proximal convoluted tubule because it's close to the capsule. And that's when you're going to first start to do things like secretion, reabsorption, and then you're going to go down deep into the medulla of the kidney with the loop of Henle. Again, Henle is a person who discovered it. And then, as you can tell, it's getting more yellow. Now you're going to have it come up to the distal convoluted tubules because they are far away from the cup. And all this time, whether you're talking about the convoluted tubules or the loop of Henle, you will have these secretions and reabsorptions be going on as the kidney is trying to not only get rid of waste products and toxic products, it's also going to try to adjust the pH. It's going to try to make vitamin D. It's going to try to adjust your electrolytes. It's going to try to adjust your fluid volume. So having said that, when you come to the top of the collecting duct, the urine is very dilute. So this is where a salt gradient is made down here in the medulla that slowly, by osmosis, reclaims a lot of that water into the capillary bed. So that if you come down the collecting duct to the very bottom, it's extremely concentrated. We excrete about 1.5 liters of urine a day. And if we didn't have that mechanism, that osmotic mechanism in the medulla to reclaim a lot of that water from the dilute urine that's coming off of the distal convoluted tubules, it would be like 150 liters of fluid would have to be processed a day. And that certainly could not sustain life as we know it. So yay for osmosis. So then the urine then would come out of the pyramid, collect in the renal pelvis, and then go out the ureters to the bladder to the urethra. Okay, so having said all that, the first we're going to tackle is pre-renal. Can there be events that happen before the kidney that affect the function of the kidney? And the answer is yes. And dehydration or hypotension, you could put hemorrhage down here as well. This has to do with the fact that if you have a sudden decrease in blood volume and blood pressure, you're not going to be able to filter into Bowman's capsule because blood, any fluid, whether it's blood or filtrate or urine, it passes high to low pressure. So if your blood pressure is robust, then you have no problem. You are going to filter a certain volume and purify that. Ta-da! If, on the other hand, there is some pathological event before the afferent arteriole, such as hemorrhage, such as sudden dehydration through overexercise, lots of ways that you can become hypotensive, then that means you're not going to filter, or you're going to filter very little. And you can do that for a certain amount of time in an acute setting, but you can't do it for any length of time because it's the only way you're going to get rid of those toxins. And I also just want to mention, when you take pharmacology, understand that all drugs are considered toxic foreign poisons. And when you take pharm, you're going to find that the kidney has a big role in how robustly it's able to pull that drug out of the blood and get it out of the body. So it's a different way of looking at. We think drugs certainly do save our lives, but the body looks upon a drug, whether it's aspirin or whether it's chemotherapy, as a toxin, something to get rid of. And for that reason, when you do pharm, that's what is the basis of the drug concentration. It's called renal clearance. Renal clearance is not going to be on the exam, but I just want to mention this because this will not be the last time you hear about the kidney. Okay, so if you cannot filter, then it means for a short period of time you have these toxic chemicals in your blood. And that's fine if you can then give a person a couple of units of blood or get them to drink fluid and rehydrate. And then the body will be able to remedy that problem. If it's chronic, then it's a whole different ball of wax. Right, so that is before. So if the blood pressure is so low that you really cannot filter effectively, then you cannot purify your blood. And that's pre-renal disease. So if the kidney itself is not harmed, it's just more a matter that the kidney can't do its job. All right, renal diseases. Renal diseases meaning that there's something wrong inside that network, that nephron blood network. And there are two major categories. One is damage to the glomerulus. So that would be the glomerular capillaries, Bowman capsule, that neck of the woods. And the second has to do with all those tubes, the proximal, the distal convoluted tubule, loop of Henle, collecting duct. Those are the tubes. And it's called tubulointerstitial disorders. And so that's the disorders of the tube structure. Now let's get into interstitial cells. This is the thing that very often, and I will include myself, don't emphasize enough. And that is every single one of these structures are composed of cells. And so your capillaries are endothelial cells, your afferent arterioles are that and smooth muscle and so forth and so on. When you get to the nephron, and it's really one of the reasons why the nephron is impossible to reproduce and to regenerate, is that the cells in the Bowman's capsule do totally different function than the cells of the proximal convoluted tubules. And those cells do something vastly different than the cells in the lobe of Henle versus the cells in the distal convoluted tubules versus the cells of the collecting duct. So these have cells. And so I want you to remember that cells need oxygen and glucose to do cell respiration, and then they will kick out their waste products of carbon dioxide, gas, and water. If you have chronic conditions and you are constantly not getting enough glucose and oxygen, especially to these tube cells, then they're going to experience ischemia and necrosis. And even if you just cause damage, permanent damage, so that the tube structure of the nephron can't work, none of the other cells that are left behind can take up their function. So this nephron would be dead in the water even though the glomerulus wasn't damaged. If you did something to directly damage the glomerulus and then that goes down, even though you might have a perfectly fine tube structure, it cannot take on the job of the glomerulus, and then it would die. So either way, whether you have glomerulonephritis and an inflammation here in the glomerulus and Bowman's capsule, or you have some sort of tubular interstitial um, inflammation going on in the tube structure, both of those occur within the nephron of the kidney and can be damaged beyond repair. And whether it's the glomerulus or whether it is the rest of the tube structure of the nephron, you damage any one of those, that entire nephron is down and can never be replaced. So on to happier topics. Okay, so post-renal is going to be fairly easy. And this has to do with kidney stones. That's the only thing that's going to be on the exam. And I'm not even getting into a lot of the pathology of kidney stones. In people who do not have kidney stones, which is the majority of the people, they make an inhibitor that inhibits the formation of kidney stones. Because we do eat food that can have crystals, oxalate crystals, phosphate crystals, accumulate and be formed in the nephron. And if that happens, then you end up making this crystalline kidney stone that can get caught in the ureters and obstruct the flow of urine from the kidney to the bladder. People who do not make that inhibitor make kidney stones. All right, I'm not going to talk about blah, 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 blah. All right, so it is considered an obstructive disorder, and the obstruction, the only one that's going to be on it are the kidney stones. But here comes the real deal. If you have a kidney stone, that is going to obstruct in a major way the flow of urine from the kidney to the bladder. You are going to have a swelling in that ureter at the site of the stone, and that can be picked up in imaging, and that is called hydroureter. Sometimes the backup can actually occur in that distal portion of the nephron, the pelvic area, the calyces, and that can cause a swelling of the kidney, and that is called hydronephros. And if that is not relieved, then that can cause problems. Kidney stones tend to be fairly painful, and it's something that is difficult to ignore. So most people do seek medical attention and the stone is cleared. And as long as it doesn't become chronic, very often the acute episode passes and the person is fine. No. And you don't have the slides, you can put an X through it. That's just going into the different types of kidney stones. All right, so now we're into intrarenal. We've done before, we've done after. Now let's get to the kidneys nephron itself. The first one we're going to do is tubulo-interstitial disorders. So what can happen at the tube? And so the more common of the acute pyelonephritis comes as a result of urinary tract infections. So I'm going to just go back to this diagram. Hello. Getting there. Here we go. So women tend to have urinary tract infections more than men. And you can be a woman and have lots of urinary tract infections and never have it become pyelonephritis. But every time you have a urinary tract infection, it's a possibility. So you have a urinary tract infection and it's going like gangbusters, and it's starting to irritate the lining of the bladder and irritating the ureter. Now, the ureter can respond by doing reverse peristalsis. So up comes this lovely infected urine, and then all of a sudden it's at the pelvis of the kidney, right here. And it's infected urine, right? So, needless to say, it's going to start all kinds of inflammation. And the inflammation with pyelonephritis tends to be the pelvis, these calyces, sometimes the pyramid, but it tends to be that middle portion of the kidney and not the cortex where the majority of the nephrons are. But the tube part of the nephron is definitely in the medulla. So again, if it's a one-time thing, it's extremely painful, you get the antibiotics and the anti-inflammatories into a person, and it's a one-time thing, it doesn't have to result in permanent damage. If it becomes chronic, then that becomes a different story because um, very often you're then having this occur over and over again, and you then worry about drug resistance, you worry about permanent scarring of the kidney, and things of that nature. So usually and hopefully it's a one-time thing. Now, we went from there to Hayo. Okay, and that's the acute pyelonephritis, right? Inflammation. It tends to have that reflux into the kidney via the ureter of the infected urine. And so you have the pelvis and the calyces and the medulla might get involved. And if you catch it on time, fine. Otherwise, you can have scarring and atrophy of the affected tubules. Then you would be down a certain amount of kidney function if that happened, because you do not want to have scarring or atrophy occur. All right, now chronic pyelonephritis is when you do have that rare patient that has a uh, recurring urinary tract infections with pyelonephritis complications. And it can lead to chronic renal failure if you can't get a hold of the urinary tract infections, and so forth and so on. So that is when it becomes extremely damaging. All right, now we're going to get into the glomerulus. These are some terms, you hit them in normal A&P. Let me go over them very briefly. You can have, with glomerular disorders, changes in membrane permeability. You want to get the small toxic molecules that are in solution out. You don't want to get rid of and have your red blood cells in your urine. You don't want your white blood cells in your urine. You don't want big plasma proteins like albumin in your urine. That's incredibly pathological. That means that the membrane permeability is not discriminating between cells and tiny chemical solutes in the urine. And so the filtration is off, and it's not good. All right, so what would be happening with the change in permeability? Changes in GFR. G is for glomerular, F is for filtration, and R is for rate. The glomerular filtration rate is a fancy term for how fast you can filter the blood and get rid of the toxins. And we'll find out with a lot of these pathologies, it will compromise and lower the glomerular filtration rate, and that leaves the person vulnerable. You can, because of changes in membrane permeability, have abnormally large proteins or blood cells in the urine, and you can also have systemic changes. So, depending on the disorder, it can have a secondary hypertension, secondary edema, secondary acid-base and electrolyte imbalances. And those are things that should have been gone over along with fluid balance in AMP1. And if not, brush off those cobwebs. Okay, here's a cross-section of the nephron and Bowman's capsule. I'm sorry, of the glomerulus and Bowman's capsule. It's worth looking into. What I want you to look at especially is, okay, here's your afferent arterioles, bring in the blood in. Now you're going to, at this juncture, this is Bowman's capsule, and then these are the cross sections of the arterioles and the capillaries. You are very concerned with the very fragile, sophisticated glomerular capillaries ripping, tearing, bursting, because you can't repair them. And that's where you filter. So you have two protective mechanisms that help maintain the integrity of the glomerular capillaries. So if there's a slight change in pressure, they're not going to blow out. The first is this mustard color that's going around about, what would you say, 75% of the capillaries of the glomerulus. And it's called the basement membrane. Here we go, right here. Glomerular basement membrane. I think of the glomerular basement membrane because it's not a cell. It's a series of proteins that act like a girdle, and they kind of hug the capillary loop. So if there's a little bit of expansion, it's going to limit how much it can expand. The other are these gray cells right here, these dark gray cells, and they are called mesangial cells. And these mesangial cells can expand and contract. And again, they are protecting that area of the glomerulus, which is not protected by Bowman's capsule. So Bowman's capsule comes around like this, but it doesn't make an entire loop. And then the mesangial cells fill in that gap. Why? Because mesangial cells have a little bit more plasticity. They are a little bit more able to robustly expand and contract versus the glomerular basement membrane, which is an extremely good girdle, but it just doesn't have the elasticity and the malleability of the mesangial cells. Mesangial cells become important with non-compliant individuals who, for a long time, 10 years out, 20 years out, with diabetes mellitus. And having said that, what would then happen is that you would have filtration from the glomerulus into these spaces in the Bowman's capsule. And then they would travel into the proximal convoluted tubules and down. And because we haven't yet separated the good and the bad, then we call it a filtrate. And then we can reabsorb what we want back, like glucose and water, at the level of the peritubular capillaries. We can adjust our electrolytes, we can adjust our pH, and we can then concentrate that urine and then have it leave the body. So, having that, all right, so we are now into glomerular nephritis, inflammation of the glomerulus. And what I would like to actually talk about first is going to be Goodpasture syndrome. It's actually easier to understand. Goodpasture, named after Dr. Goodpasture. It's an autoimmune disorder. It mainly affects men, and they're going to be young men who suddenly the body starts to see their basement membrane of the glomerular capillary and pulmonary and lung. But this is not a lecture on lungs. This is not a lecture on pulmonary. But the autoimmune of Goodpasture we're going to emphasize on the exam is what happens at the level of the kidney. So inflammation, occurs, and so you have inflammatory, inflammatory lymphocytes, complement, which is also involved in immune responsiveness, phagocytic neutrophils. And the glomerular basement membrane is what is going to come down, because the glomerular basement membrane is what the body very wrongly sees as foreign or different. There's nothing foreign or different about the basement membrane. How that happens, who knows? But it's going to kill the person. So they are going to have episodes of acute inflammation where the autoantibodies bind to this basement membrane. And when you have inflammation, you're bringing in all these inflammatory cells, all these inflammatory mediators. You're starting to get fluid buildup. And what ends up happening is you end up killing off these cells that are in the general neck of the woods. So the inflammatory mediators, the cytokines, T reactive cells, edema, are all going to be affecting not only the basement membrane, but also the glomerulus and all of the cells in the Bowman's capsule. It's called innocent bystander injury. So these are innocent cells, but they are going to go down because of the inflammatory response, and you don't get them back. That's the problem with it, is that once you have destroyed that nephron, even partially, so it cannot do its job, then you're going to have permanent damage to that nephron and be down a certain amount of renal function. Okay, so with good pastures, they're going to have their times of acute episodes, times of remission, especially using strong anti-inflammatories. But they are kind of a tiger by the tail because you can depress the person's immune system so much in good pastures that they become like an AIDS patient. So you're always between a rock and a hard place. And usually within 10 years of diagnosis, the person dies. And I'm just going to emphasize the acute and eventually chronic glomerulonephritis. I'm not going to go into the lung. Okay, so that just goes into that. Let me go back to the second glomerulonephritis that can be caused by some individuals recovering from strep throat. So this is an acute glomerulonephritis associated with streptococcal infection. So you have streptococcus and you get a strep throat. And what happens is you are given antibiotics and you take them and strep throat is fine and we all live happily ever after. There are some people, we don't know who they are until they appear, that have a strep throat. And then 7 to 10 days later, after they've taken their antibiotics and their throat feels fine, they have something very unusual happens to the antigens, those molecules on the surface of this strep that causes an immune response. What should happen or does happen in people who do not have this syndrome is they end up just taking the strep that's dead along with the antigens. You filter it out of the body, you pee them out of your body, you live happily ever after. With people who have this streptococcal glomerulonephritis, the streptococcus dies, but the antigens get caught in the basement membrane. Now, why that happens, we don't know. But that it does happen, that's harmful because now you've got you set up for the body's immune system thinking that all of a sudden the cells in the glomerulus are coated with strep antigens, so they have to be pathogens. So we have to go and get an inflammatory response to get rid of those pathogenic antigens, which they will do, except the fact that they now are destroying by innocent bystander injury all of the, not all, but enough of the cells in the glomerulus so that the glomerulus and Bowman's capsule are destroyed. And then that person is permanently down a certain amount of kidney function. It is an extremely painful situation, so that usually it gets caught enough, and if it's a one-time deal, the damage tends not to be permanent. If it becomes chronic, that becomes quite different. Because then you can start to accumulate the progressing renal failure, and that could lead to end-stage renal failure. So that is the very unusual consequence of a strep throat. So that's streptococcus antigens causing acute glomerulonephritis. Let me go over some of these terms. Hematuria means that there are red blood cells in the urine, or hemoglobin. Proteinuria is going to be the very large plasma proteins, which should not ever penetrate through. Decreased glomerular filtration rate. That is kind of an obvious one if the whole glomerular apparatus is inflamed. Oliguria means that the urine output goes down. Hypertension and edema and ascites can also be a consequence of acute glomerulonephritis. And that's it for acute. Now we're going to go into chronic. So the thing about chronic is going to be over a period of time, you can have problems with glomerular filtration rate. You can cause damage to the membrane permeability, which means loss of blood cells and protein. You can end up not purifying the blood properly, not being able to adjust the pH, to adjust fluid volume, to adjust vitamin D synthesis. All of these things can happen if you have a chronic condition that keeps hitting the kidney, and after each episode, you've lost a certain amount of renal function. So the two that I want you to know for this exam is diabetic nephropathy. Here we go. And then systemic hypertensive nephropathy. So let's go into the diabetic. So this is going to be a non-compliant diabetic, and that can end up creating elevated glucose. Non-compliant diabetics tend to have hyperglycemia, and for whatever reason they can't get a hold of it. It happens, and over a period of years, decades, but the cell that becomes remodeled by the constant and pervasive hyperglycemia is the mesangial cell. So here it is right here, mesangial cells. Mesangial cells just really, with that hyperglycemia, that becomes a long-term trigger. It doesn't happen with acute episodes, but if you're a non-compliant diabetic and the hyperglycemia is pretty continuous, then the mesangial cells will get to a tipping point, beyond which they are not going to be working. And that means that they are not going to be responding to changes in pressure, blood pressure, changes in the pressure at the glomerulus, and so forth and so on. And over a period of time, that entire glomerular network, the glomerulus and the Bowman's capsule, breaks down as the mesangial cells start to, as they're remodeled, start to affect glomerular filtration rate and membrane permeability, etc., until you get massive nephronal death and eventually end-stage renal disease. But it's all about the glomerulus. Systemic hypertension, either a non-diagnosed or non-compliant person, can also cause chronic nephropathy and can also lead to end-stage renal failure. But it's a very different ball of wax. Yes, it certainly can. The hypertension can increase the pressure in the glomerulus. But in addition, and this is what I'll emphasize, because what happens with hypertension nephropathy is it's going to, over a period of time, cause the destruction of the tube structure as well. And that's unique. So over a period of time with the hypertension, it means that you don't have enough oxygen, glucose, to get to the cells in the tube. And they will experience ischemia and hypoxia, necrosis, death. And without the tube structure, the nephron is dead in the water, just as without the glomerulus, the nephron is dead in the water, and the person is permanently down a certain percent of renal function. So it's not the mesangial cells, it's about the viability of all the cells that are making up the nephron. And that is going to eventually lead to end-stage renal failure. In both cases, the diabetic nephropathy and the hypertensive or hypertension nephropathy, they're not going to be high on a transplant list, either as a person with good pastures, because the underlying pathology or pathophysiology is not addressed. Okay, on to our next world adventure. A little bit about renal failure and what you can pick up on the diagnostic side with just a couple of blood samples. All right, acute renal failure. Well, let's say that you're severely dehydrated and the blood pressure is low and you're not doing filtration, so you have this abrupt decrease in renal function because of the dehydration. You have a decreased glomerular filtration rate because of the loss of blood pressure. An increase in BUN, blood, urea, and nitrogen. Because you're sampling blood, that's why it begins with blood. Urea and nitrogen are toxic waste products. And so the BUN should be low in people without renal problems. You can have a person who is dehydrated that suddenly has an increase in BUN because you can't filter, and what you can't filter, you can't purify, and that then means that the waste products are accumulating in the blood and you can pick them up. Creatinine is another thing that they will measure because it's another waste product that does have to be dealt with by the kidney, and if the kidney is not functioning, then that's not going to happen. So you would have, let's say in a case of a person who is severely dehydrated, they would have a decreased GFR, they would have increased BUN, increased creatinine, they would have oliguria, very little urine would be lost because very little blood is filtered. Most of them are reversible, hydrate that person. But if it becomes a long-term situation, then you can have acute tubular necrosis. Why? You can't get the oxygen, can't get the glucose, and then the cells get starved long enough and they go down. So those are the things that they can tap into very quickly. All right, so that is just kind of background, and we've gone over that before. Chronic renal failure, the two that are important are the diabetic nephropathy, hypertensive nephropathy. I mentioned this before, but I'll just mention it briefly again, that if you have the pyelonephritis, you have the urinary tract infection, and you get that reverse peristalsis, and you start flooding that kidney, and that becomes chronic, then you can start to scar those tubes, and they become necrotic, and it's just that infected urine and the inflammation and the innocent bystander injury. So it is pyelonephritis can be chronic. Kidney stones also can be chronic and can lead to renal failure as well. The two that I'm going to emphasize are going to be the diabetic nephropathy and the hypertensive nephropathy. But I do want you to realize that anything chronic that starts to whittle away at the nephron, its structure, its function, over time you accumulate that damage, and all of these chronic kidney stones, chronic pyelonephritis, chronic diabetic nephropathy, chronic hypertensive nephropathy can all lead to end-stage renal failure. Okay, and then what is end-stage renal failure? It means that the body no longer has the ability to get rid of the toxins and can develop uremia or uremic poisoning, named after urea, one of the major toxins that the kidney's very good at getting rid of. Um, and a person who is in the throes of uremia or uremic poisoning, probably dialysis is the next stage, or a kidney transplant. Okay, so that is it. And I will see you in a bit. So have fun, be safe, and I will talk to you soon.